Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, and our goals are to spark conversation, ideas, and action. Since we're live, I want to remind everyone that while we don't take questions over the phone line, you all have the opportunity to type your questions into the question box at any time during the webinar. I'll check the webinar for the questions at the end of the session, but please don't feel like you need to wait until the end of the presentation before you start typing your questions. Just go ahead and put them in as you think of them. We're delighted today to be joined by colleagues from the Canadian Paediatric Society and many of our member organizations for acute management of pediatric COVID-19. This webinar focuses on the Canadian Paediatric Society's practice point on acute management of COVID-19, including key recommendations. And the statement was written by core members of the Acute Care Committee of the Canadian Paediatric Society in consultation with multiple committees and sections and the Board of Directors of the Canadian Paediatric Society, together with multiple stakeholders. For those of you on Twitter, please tag us at ChildHealthCan to any webinar-related tweets and share away. I'd like to welcome our speaker for today, who will introduce his co-presenters. Dr. Kevin Chan is the Medical Director and Division Head of Children's Health Trillium Health Partners and Associate Professor of Pediatrics at the University of Toronto. And he's the current chair of the Acute Care Committee of the Canadian Paediatric Society. It's my pleasure to welcome Kevin and pass the mic to him.
Great. Thank you very much, Paula, for inviting us and having this opportunity to talk about our paper on the acute management of pediatric coronavirus disease 2019. My co-presenters today include a great group of people, starting with Laurel Chauvin-Kimoff, who is a Peds Emerge Doc at Montreal Children's Hospital and Associate Professor of Pediatrics at McGill. Christina Krempodic, who is a Peds intensivist over at IWK in Halifax, Nova Scotia, and she's also Assistant Professor. Carolyn Beck, who is a Peds hospitalist at Sick Kids in Toronto and an associate professor there. Evelyn Trottier, who is a Peds Emerge Doc at St. Justine and assistant professor of Peds Emerge Medicine at University de Montreal. Karen Grip, who is also a Peds emergentologist in Manitoba and associate professor there, and Sid Thakor, who is a Peds hospitalist at Alberta Children's Hospital in Calgary. Today's presentation will be given by all of us. I will be the speaker. One of the caveats we will say is we don't have all the answers, but this is certainly the best guidance we could come up with at these early stages of the COVID-19 pandemic. We estimate that we'll probably need to modify some of the guidelines within a month. And the reality is that this is a dynamic situation that is constantly changing. I also want to acknowledge the CPS and certainly the leaders, leadership and staff there that helped us shepherd this guidance over about a 3-week period. And the various committees and sections and the board of directors. We'll tell you, we received feedback from about 35 different individuals, totaling about 40 pages of comments on our very little paper. And so they deserve as much credit as we do for making this paper work. And we also want to just acknowledge and thank each and every one of you for coming. For those of us on the front lines of this pandemic who risk their lives each and every day, we, the Acute Care Committee, wrote these guidelines on an extremely expedited pace to get some helpful information out to you. All of us know someone who has been affected by the pandemic. We have colleagues, either doctors, nurses, or other healthcare workers who have gotten sick. Maybe we have a family member who has caught coronavirus or worse, has died from it. So we just want to take this moment to say thank you for what you're doing. So up front, we'll disclose that there are nothing to disclose. Our learning objectives for the day are to talk about these 8 issues. 1, the clinical presentation of coronavirus in children. 2, clinical severity definitions. 3, screening and protection guidelines. 4, information around aerosolized generating medical procedures. 5, diagnostic testing guidelines. 6, treatment and therapies not yet supported by evidence. 7, the treatment of croup and asthma in the COVID-19 era. And 8, post-discharge planning. So as of April 28th, from the government guidelines, about 1,272 children's cases, these are all children up to 18 years of age, including the 18th birthday. 1,272 cases exist out of the 27,000 cases, or 4.7% were in children. And this represents a minority of the burden. As of April 20th, when we reviewed this for publication, there were 11 global studies that presented symptoms for children. The minimal case sample that we took was 3, and this included about 643 patients, and 8% of these were asymptomatic. There is now another study from Italy that has been tentatively submitted for review, but has not been peer reviewed. And they have a much younger age categorization of patients of about 2,000 children. The definition of asymptomatic, when you take a look at these studies, is of course biased. Most of these figures go from groups that are unwell enough to require testing. So the asymptomatic may select from a much sicker sample. If they're presenting with clinical symptoms, what are they presenting with? 57% of children present with fever, 54% with cough. When you compare it, the adults respectively are 83 to 99% with fever, and in adults 59 to 82% present with cough. 29% of kids present with sore fever, 8% with rhinorrhea, 11% with diarrhea, and 9% with vomiting. There are a whole slew of other symptoms, including fatigue, headache, myalgia, poor feeding or poor appetite, and nosmia, which is loss of smell, and ageusia, which is loss of taste, have also been described. So there are a number of clinical symptoms that they are presenting with. I think one of the things that I would pay attention to is the group with diarrhea and vomiting. These symptoms tend to persist. And in stool testing, some of the tests have gone beyond the 2-week window that we've heard. And there is evidence that they may be going as far as over about a 4-week period. So it is important around hand washing and gloves are also imperative around COVID-19 patients. Many of you have also heard that COVID-19 presents with skin changes in children. Elena Pope, who's the head of dermatology at Sick Kids, is part of an international study that has seen vascular rashes around the extremities, including acrocyanosis, perineal-like changes, and acroischemia. The Italian studies have shown that this may be occurring in up to 20% of COVID-19 positive patients. And so this is a finding that is important to take a look at. The other thing that's important is that young children are more sick than older children. So when you take a look at the big Chinese paper, which is written by Dong, one of the things in children is that the youngest children certainly appear to get more sick, but thankfully, as is widely reported, most children do well. The admission rates were estimated in the CDC paper recently released in Morbidity and Mortality Weekly Report. And it really showed that the admission rates were estimated somewhere between 5.7 to 20%. And the vast majority of admissions were in children less than 1 year of age. And if they're admitted to hospital, about 3% will die, according to the CDC information. So the key takeaway points are this. Children have less fever and less viral URTI symptoms than adults with COVID-19. In general, they look better. Vomiting and diarrhea occur in about 10 to 20% of children. And so COVID-19 must be considered in children presenting with gastroenteritis symptoms. And the third thing is, if you're seeing extremity vascular rashes, you need to investigate for COVID-19. So I think those are the key points for us to highlight. So the other question is, what is the asymptomatic rate? So from the global studies, it's around 8%. The best study actually to date is actually in Iceland. And so this is one of these really important research questions, is how much is being transmitted through children. So as I said, the Iceland study probably is the best study. It was done by Decode Genetics. And it really showed that in children less than 10 years of age, when they have symptoms, the rate's about 6.7%. But they also did an interesting part of the study, which was they actually sampled the population as a whole. And when they did a population sample that was taken, it was 0. So they didn't actually get children with significant asymptomatic rates. But this is an early study. If you look at the Icelandic population, their case rates are relatively low. I think more population studies need to be done, because it will help us answer the question, is it safe to send children to school? And will they transmit it when they come home? As many of you have heard recently, Quebec is about to open the schools. And in doing so, the question is, will it cause a second wave of COVID-19 to occur? And these are questions that are imperative for us to try and answer. So the key takeaway points are this. If there are symptoms, test. There are a lot of children who are probably asymptomatic, but we really don't know what the percentage is right now. So I think it is prudent for us to be careful. There is certainly asymptomatic carriage that is occurring. And when you think about parents and maybe children, each encounter increases your risk. You need PPE, even if you're seeing patients in your office. And I think the other side of things is physical distancing is going to be important for a while until we find a vaccine. And so I think that's an important consideration. So this is a table that summarizes clinical severity of COVID-19 pediatric patients. And this was a grading system that we synthesized from a combination of Chinese data from their original papers, by Chen. Dong's paper adopted something similar, and so did the World Health Organization. What I think is essentially think of it as a gradient. When you're in the severe side of things, you should definitely consult infectious disease and pediatric critical care and consider transfer to a regional or tertiary center. Obviously, for the critical child, they need to be sent to a tertiary care institution. So those who are there are going to be sent to the best care possible. But certainly from this side of things, this is a rough gradient system that is usable. When it comes to screening, I think it's really important to realize that children can get affected. The common modes of testing include the nasopharyngeal or throat swab. You're starting to hear a fair bit around serology testing, but that's still not yet onto the market. The only major study looking at the comparison between nasopharyngeal and throat swabs showed a marginal benefit of the nasopharyngeal swab, and really it was not statistically significant. If there's any concern, my bottom line would be consult your infectious disease or pediatric critical care specialists sooner rather than later. So for the protection guidelines, it's important to remember that it's both droplet and contact transmission. But the bottom line is that you should follow your local, provincial, or territorial guidelines. The development of the guidelines takes into account their various PPE requirements and the potential issues around the burn rate around PPE. So when seeing patients in general, especially ones with suspected or proven COVID-19, you definitely should be wearing a mask, gown, gloves, and some sort of eye protection, especially with the risk involved. If possible, and many hospitals are doing this, patients, if they can wear their mask, should wear a mask, and parents should be given a mask and told to wear it, especially if they have respiratory symptoms. So we're starting to see a lot of patients being guided to have a mask when they. For anyone who is doing an aerosolized generating procedure, and I'll talk about what is an aerosolized generating procedure in a second, on a confirmed or suspected COVID-19 patient, you should wear full protection, including an N95 mask. Once again, we would suggest referring to your local, provincial, or territorial guidelines. Ideally, it should be done if you have with a negative pressure room, with a closed door and limited access. And I'll talk about protective barrier enclosures in a second. When it comes to what is an aerosolized generating medical procedure, I think, once again, we will say follow your local and or provincial territorial guidelines. From what we can garner from the literature, there are things that are definitively considered aerosolized generating medical procedures, and there are things that are definitively not. And there are a lot of things in between that are debated depending on what your source of information is. So it's clear that there is enormous variation across the country, and this is at our time our best estimation of where things stand. But we also recognize that these decisions will remain fluid. And so what one jurisdiction would consider an AGMP may not be in another jurisdiction. And it was very clear when we developed these guidelines that there is enormous variation across the country. The other thing that you're starting, if you're looking at options to think about, this was originally designed by the Taiwanese company to try and reduce the risk of aerosolized generation during intubation. And it's a simple box to try and reduce the aerosolization spread during that process. The evidence of the value is still waiting to be seen, but in many ways, it makes sense to reduce the risk of droplet contamination. And so we're starting to see some institutions use this. And so that is an option to consider. I think it goes without saying that the fewer people that can be at risk of exposure, the better off we are. It's important to think about who really needs to be in a patient's room. And so the thinking is we really also need to be careful around testing, and do we really need the tests, or are we risking exposure to our healthcare workers? If you can, I would say dedicate equipment inside the room, for example, dedicated stethoscopes, or if not, ensure that in between every patient that your stethoscope should be wiped down. In clinic and ER settings, it's important to remember to clean the room and all equipment used between patients. You're starting to see virtual communication may be necessary with parents in rooms. I've seen everything from whiteboards to iPads to writing on glass screens. If you really don't want to go inside the room, there are various ways you could communicate. And so using virtual communication is an option. From a diagnostic testing perspective, diagnostic testing, as we said before, is either with nasopharyngeal or throat swabs. At some point later in the year when the viral season comes back, you may need to test for other viruses in addition to SARS-CoV-2. And co-infections certainly can occur between SARS-CoV-2 that causes COVID-19 and other viruses. That's certainly been reported. I think blood work and imaging really should be reserved for sick children. And when it comes for diagnostic imaging, if you need to do a chest X-ray, or if there's skill and equipment, you could do a point of care ultrasound of the thorax looking for pneumonia. And one of the chest X-ray findings that we're starting to see is a fair amount of a classical ground glass appearance on chest X-ray. And if your kids are severe, you might actually need to consider a chest CT. And this is currently under the various guidelines. And so certainly kids who are more severe, consideration of a chest CT is there. Treatment's mostly supportive. I would say treat fever. So with acetaminophen or ibuprofen. Prior concerns around ibuprofen use has not been borne out so far. And many of you have heard earlier studies suggesting a potential link with ibuprofen and increased morbidity and mortality. And as I said, there is no evidence as of yet. Other supportive treatment obviously include oxygen and hydration, either through intravenous or nasogastric methodologies. If you do need to intubate, you really want your most experienced airway person. The one thing we didn't write in the article and we debated was around the use of video laryngoscopes for intubation. You may actually have anesthetists who are much more comfortable using it, and or specialists that are used to using it. So if you have the video laryngoscope and someone skilled to use it with the right blades appropriate for children, I think that should be a consideration as well. And also antibiotics, if there's a possible co-infection such as sepsis and or pneumonia, the medications to use are there. So IV third generation cephalosporins, plus or minus vancomycin. For pneumonia, either PO amoxicillin or IV ampicillin are reasonable options. There are a whole bunch of different drugs that are being touted as cures for COVID-19. There are a number of studies going on with a variety of treatment. As of yet, none of them have been proven to work. You're starting to see a whole bunch of different antivirals being tried, at least in the adult populations, there are a few children's trials that are starting up now. And so we're seeing them in remdesivir, you've seen lopinavir, ritonavir, which is Galetra. You've heard definitely President Trump talk about hydroxychloroquine. So certainly there are a lot of different antivirals out there. There have been discussions around corticosteroids, but there are also similar concerns. In fact, that corticosteroids may actually be harmful. There's been theories around IVIG. You've also heard around plasma treatments, angiotensin converting enzyme inhibitors and angiotensin receptor blockades have been going under therapeutic trials. And IL-6 receptor antagonists such as tocilizumab are also being used in trials currently. Right now, many of the tertiary centers have developed consensus or a process for consideration of some therapies in select populations, but really they shouldn't be used without consultation with an infectious disease specialist at these centers. And so there are therapies that are being tried. There are trials that are starting to occur. Although the vast majority are in adults, there are a few that are starting in kids, and we should hear more about this relatively soon. There are a few groups that require special considerations for referral. The list is here. That includes infants, children with heart or lung disease, neurological or neuromuscular disorders, chronic conditions including diabetes, sickle cell malignancies, immunosuppressive conditions, and home ventilated patients. And these children should be taken, consideration should be taken to consider referral to a regional or tertiary center sooner rather than later. There's a few things that are a little bit different in the COVID-19 era that we'd like to emphasize a couple of disorders. So one's around acute asthma. And I think the bottom line with acute asthmatics is you still have to treat the underlying asthma. So it's really important to remember that there is a risk of using nebulized treatment. And there are options such as a meter dose inhaler or dry powder inhalers that should be utilized whenever possible. Using steroids is still appropriate, especially baseline inhaled corticosteroids, as per the Canadian Thoracic Society recommendation. However, our colleagues at the Drug and Therapeutic Committee want us to be careful and cognizant of steroid use. As stated earlier, steroids may worsen COVID-19 symptoms. When we get severe asthma, what we are suggesting is to consider using IV magnesium sulfate early, and also consider, if not working, to use IV salbutamol earlier. So these are options that are available. When it comes to croups, I think we need to use steroids appropriately as needed. In some of the older children with mild symptoms, you may consider deferring. And for severe croups who are stridorous at rest, the traditional treatment is nebulized epinephrine to buy yourself time. What is making its way back onto the market is an MDI for epinephrine. I know Sick Kids Emerge is certainly using it, but other EDs across the country are starting to use it as well as some community hospitals. So right now, the one thing we will caveat this is that the evidence is still very limited. And these are the recommendations for different guidelines that we've seen. The CPS guideline, when we developed it, was using two different references. The original guideline from the original paper in 2000 in pediatrics, and there was an appropriate FDA review of the product in 2018. It also mirrors what was done in a number of northeastern children's hospitals in the United States as an option to nebulize epinephrine. So that's where these guidelines got developed from. In the absence of having access to epinephrine MDI, another consideration would be around epinephrine IM or subcutaneous, and the dosing that is available is right there. So cytokine, I just want to make a comment that there is a mechanism in adults where there's a group of patients who are dying from what is called a cytokine release syndrome, which is characterized by high fever and multi-organ dysfunction. We haven't seen a ton of that in kids, but what you've heard probably over the past week or so is this SARS inflammatory syndrome. It has multiple names, but basically it has the features of a toxic shock syndrome and an atypical Kawasaki disease with blood parameters consistent with severe COVID-19. So you've heard the warning through the NHS in the UK. There are certainly reports coming out of Spain, Italy, and the United States around this. A lot of these kids have abdominal pain and gastrointestinal symptoms. I think it's important in the UK, the 12 UK studies, that not all these children actually tested positive for COVID-19, and none of them have died. And the treatment that they've used is very much standard to what they use for Kawasaki disease, which was IVIG and aspirin. So this will definitely come up in our next update to the original paper. When it comes to post-discharge planning, I think it's important to remind parents, if the child is well enough, they need to self-isolate for 14 days and a minimum of 24 hours symptom-free. I think it's important to give them signs and symptoms of when to return back to hospital. And certainly if they're at higher risk, consider referral to your regional and tertiary center after consultation with your infectious disease colleagues and or pediatric critical care. And if they're sick, as I said, contact your ID and or pediatric critical care physician and consider transfer sooner rather than later. So what I will say is this: COVID-19 is a challenge. Thankfully, for the vast majority of children, they do well, and the evidence is rapidly changing for COVID-19. I think it's paramount that we take care of ourselves, as I think the higher risks are parents and other healthcare workers, but we're also going to have to be extremely careful when the schools open up if it puts undue risk back onto healthcare providers. Many children, even if they do get COVID, do well. Only a very small percentage get sick enough to require hospitalization. And thankfully, few get sick enough to die. However, there are some groups at risk, and we need to be cognizant of those groups. We will also need to readjust how we treat some respiratory disorders, especially asthma and croup, and at least rethink the risks of nebulization, what the costs versus the benefits are. And finally, we would like to reiterate our thank you to you for being in the front lines in these very trying times. We hope this seminar or webinar produces some guidance of what to do. We also realize that we're probably going to need to revise as the literature comes out and changes best practices. So we'd love to hear your questions.
Thank you, Kevin. On that note, I'll remind folks to type their questions into the question box, and I'll read them out for Dr. Chan to address or pass along to one of his colleagues. We've got a few questions already in the question box. Younger children are shown not to do as well as older children. How about children with complex medical histories? Is there evidence to show that these children do worse than the average child?
I don't know if any of my colleagues want to answer that. I think there is at this stage no evidence definitively. I just don't think the literature is out there that I can see as of yet. I've been tracking the literature pretty religiously. There's just no data at this stage.
I can speak briefly. This is Christina Paediatric. I'm a peds intensivist out in IWK. I can speak briefly about what's recorded in the VPN database, which is the North American database of PICUs. But I think it's important to note that a lot of our PICUs across North America have actually broadened to include patients up to age 40. And so the data is a bit hard to interpret because about 50% of the data comes from, 50% of the cases are patients age 18 to 40. That said, with respect to the number of younger patients, so to date, it looks like there's about 37 cases, less than 2 years, in North American ICUs, which at this point initially accounted for probably a third of the cases in mid-March, and now are accounting for only about 10% of the cases in PICUs across the country, across North America. In terms of the North American ICU admissions and people talking about comorbidities, so again, this data is based on 296 admissions, which includes half of the patients between the ages of 18 and 40. But about a third of all of these patients are previously well, a third have a mild comorbidity, and a third have a moderate to severe comorbidity.
You. Another question about chronic medical diseases. Do you consider asthma as a risk factor of severe infection? Only moderate to severe asthma? This commenter says there's not so much evidence and there is a theoretical risk, is there not?
Does anyone want to try and answer that?
I'm happy to take a stab at that. It's a really good question, and the corresponding question is, of course, whether this is Karen Grip, by the way. The corresponding question is whether we should be restricting steroids in mild cases as well. That kind of goes hand in hand. There's not specific data yet, as Kevin mentioned, on patients with asthma, specifically in coronavirus. What's been seen in other viruses is that it's been a trigger for asthma exacerbations, and that hasn't been as reported in patients with asthma. The pulmonary pathology is somewhat different with coronavirus. So it's a good question. There's not data, but we need to be very cautious with that. I think the bottom line with steroids, and again, using your local infectious disease recommendations, of course, is that we do run the risk of undertreating asthma if we have an overhealthy fear of coronavirus, and that can lead to complications as well.
If it's evident from St. Justine's Hospital, I totally agree with Karen on that point. And if I can add to this, the Canadian Thoracic Society have made an asthma position statement where they state that it does not appear to be an increased risk for the asthma patient to acquire the COVID-19 compared to the general population at this stage.
Thank you.
I think from the standpoint of more advanced management of these patients as well, if they're requiring respiratory support, I do think, although it's important to consider timing of intubation for some of these children in general, for the few pediatric patients who do require intubation, patients with comorbidities, in particular asthma and some neuromuscular conditions, I think we have to be mindful of the importance of still using non-invasive ventilation therapies, because the risk of intubation and ventilation in an asthmatic patient obviously still exists. And by jumping to intubation, we may actually do more harm than good. And so I think keeping in mind that non-invasive ventilation is an AGMP, we should still consider using this as therapy in some of those higher risk patients due to the even more increased risk of trying to treat them with intubation and ventilation.
Thank you. Another question regarding AGMP. For a neonate, oropharyngeal aspiration or orogastric aspiration, are they different for you regarding nasopharyngeal aspiration as a AGMP?
So I'm going to caveat that statement because I think the neonatal group has done a totally, and their literature is also evolving. Ours were focused on bigger kids, not on the very, very small kids. And there is a slight variation in our statements around AGMPs. And I think the literature is really suggesting, and if you talk to the neonatologists here that are designing the guidelines, they're less concerned about the risk of AGMPs except through intubation. There are risks, so still if you're on CPAP, etc., there is still an aerosolized process, but they think the risk is significantly less. So I won't comment on the neonates because that's not what our guidelines were mostly focused at. But I will say that there is a different variation between neonates and older kids.
Thank you. Another question. This poster suggested that there was an adult in that person's family hospitalized with COVID pneumonia and were treated with ceftriaxone. Oh dear. That's it, and erythromycin. Have you heard of that use in kids?
Sorry, using ceftriaxone for?
To treat the pneumonia.
Yeah, it's an option for sure. Our bottom line is I think pneumonia should still be treated as per the guidance and pathway of the CPS paper on pneumonia. So is it reasonable to use ceftriaxone? Absolutely yes. But and it depends how sick the child is. But the guidelines right now still say first line's IV Ampicillin.
Yeah, I may just add to that too. This is Sid from Calgary. I'm a pediatric hospital pediatrician there. Agree with Kevin there. So we're still, obviously it goes down to your local resistance patterns, but ampicillin is still kind of considered the first line for community-acquired pneumonia. Unless your risk is higher, there's no reason to go to a third-generation cephalosporin. And in evidence for using azithro, there's no real evidence when it comes to COVID per se. If you think there is an atypical pneumonia, then you would consider using azithromycin for that specifically. But that's the only reason why we'd be using those medications.
Thank you. Another question. Do you have any comments on the recent reports from the UK and Italy regarding Kawasaki disease? I think you've addressed that in the presentation, but if there's anything you want to add.
Does anyone want to add to that?
I do have some information just from today, actually. I have an international group chat with pediatric intensivists around the world. And it does seem to be cropping up more and more commonly in addition to the cases that have been reported in the UK this week. So in the past 10 days, one of the hospitals in London has had 9 cases in the ICU. And a lot of those have been the Kawasaki disease-like presentation with some of them progressing to multi-system organ failure, and presently 2 patients on ECMO. So it does seem that we're starting to hear that the inflammatory response, not just with the Kawasaki-like presentation, but also the cytokine storm, is happening in pediatric patients, though with relatively low frequency compared to the overall number of COVID cases. It sounds like the symptoms and cutaneous involvement are actually happening over several weeks. Geneva currently has a few cases admitted, and one of them has coronary artery enlargement, which would suggest that certainly they were outside the range of treatment. Some of their cases appear to be responding to IVIG, similar to Kawasaki disease. And then in Bergamo, Italy, they've had 4 of these patients in the past month in the PICU and an additional 20 in hospital. 3 of them have had significant hemodynamic compromise. And in those cases, to reiterate what Kevin said, often the children themselves have not swabbed positive, likely because these symptoms are evolving over several weeks. And so they've identified coronavirus on serology, or if not on serology, the patients have had a parent test positive for COVID, either presently or more often a history of a parent having had confirmed COVID.
Thank you. Another question regarding the classification of AGMPs versus non-AGMPs. The hospital that this person works in lists ventilator circuit disconnect as a non-aerosolizing medical procedure, but when asked for clarification, they were told that we consider an AGMP, we consider it to be an AGMP when the respiratory tract has instrumentation performed on it, or high volume pressurized air is removed through the respiratory tract. I'm unsure if I'm misunderstanding this explanation, but if my circuit is disconnecting, it would be irrelevant whether or not the cuff is inflated or deflated, as the pressurized air would be exiting from the circuit at the point of disconnect, but not from the point of the patient. Just hoping someone is able to provide some clarification as to where this item should lie on the list.
So it's Christina again. We've had a lot of discussion around this in the PICU. What I would say is the discussions we've had is that once you are intubated, that is a closed circuit and therefore not an AGMP once you are on a closed circuit, which is why we are in many transport organizations choosing to intubate patients before transport. However, circuits become disconnected, and you are absolutely correct that once a circuit has been disconnected, that is an AGMP. I know various centers are trying to ration the use of PPE and potentially saying that we do not need airborne precautions when going into the room of intubated patients. I personally would not take that risk, and I would invite them to come in with me if they would like to take that risk. But I think a circuit can become disconnected at any point in time. Part of our intubation procedure actually involves clamping of the tube at the same time as we are disconnecting or reconnecting the circuit. And so even like things during filter changes by the RT on the ventilator and any sort of planned disconnect of the ventilator, we're talking about things like tube clamping in addition to our airborne precautions. So I think you've raised a very important point, and I think consideration of the fact that circuit disconnect can happen at any point in time, I would advocate that that is an AGMP and you're at risk even in a room with a patient on a closed circuit.
I agree with that.
Thank you. The EpiMDI are $600 US for 24 inhalers plus shipping. Are other centers getting this? It seems very expensive versus reserving nebulized epi for severe and using for severe cases and using with enhanced PPE and negative pressure.
I think that's a fair statement. It is expensive, and I know in our centers we're only using it really for the severe croupers. We have done agreements with community hospitals to share number of nebules so that it's not we aren't necessarily buying 24. We're actually buying about 12 and sharing it with some of our neighboring community hospitals. But it is an expensive option. But I think we balance that with the risk of the aerosolization. You can go and use nebulized epi still. You just have to use full AGMP and presume be cautious. I would argue, but it's a trade-off. If you have a safer option, I think going with the safer option is worth the cost, and that's how our hospital has viewed it. I don't know what others think. Not everyone's using inhaled epi either. Some.
Hello, it's Evelyn from St. Justin. In St. Justin, we still use epinephrine in nebulization, but of course in a negative pressure room with an iron contact precaution, and we don't have the puffers for the moment, and we keep the nebulization for severe croup, and we observe the other just giving the corticosteroid.
And this is Sid from Calgary, so I can talk more from the inpatient units, though we haven't seen much croup yet, or we aren't seeing it right now, but we have talked about using the epi MDIs, and right now the inpatient group are a bit hesitant to use it. I think if we have a severe croup, we're going to go to nebs. We're kind of prepared for it. In their rooms, doing the appropriate AGMP kind of procedure for that. I guess if we do see some more evidence come out, which I think is potentially coming out, that may change practice, but we still haven't. But there's a lot of variation. I know our Emerge is starting to use it. Avicii, go to Edmonton, I think they're using it as well. So there's a lot of variation within. So I think it just comes down to your comfort. And what you have, what resources you have there as well too. I think what may help make a decision.
It's Carolyn back here from Sick Kids. Similarly, my understanding is we're using it fairly sparingly. The MDI is currently restricted to the ICU and emergency department settings.
And from a medical director point of view, this is Karen Grip. From a medical director point of view, there is discussion about looking at this prospectively and unifying the doses. So while our paper and our slide recommends 4 puffs, centers across the country were using anywhere between 4 and 10 puffs of varying frequencies, depending on what literature they could find. All of this was really a guesstimate. The current plan is to agree on 5 puffs. That plan may change, of course, but there is some idea of trying to look at this prospectively across Canada for those of us who are using it in emergency.
Thank you. Some confusion about who to test and when. So it's confusing when we hear patients with mild symptoms or, in quotations, COVID toes, but no other symptoms, should be tested for COVID. But when the parent calls the testing center, they're told or advised that they don't need to be tested, but to continue to treat symptomatically at home. How do we know who should be tested?
I think the bottom line is it depends on your local, provincial, and territorial guidelines. If there are symptoms that are consistent with COVID, then I think you could argue to get them tested. But the bottom line is whatever your local, provincial, or territorial public health guidelines are. And you're going to see enormous variation across the country around that testing. But I don't know what others think. So it's a great question.
It's Karen Grip from Manitoba. Kevin mentioned that it's quite varying among provinces. In Manitoba, we've seen relatively few cases compared to the rest of Canada. Our total cases are less than 300, yet our testing capabilities have ramped up significantly in terms of capacity. So I can say here that we can test anyone with any degree of symptoms and clinician judgment. That may not be true in other provinces where the current prevalence and testing capacities are different. So again, very important to look at your local protocols and what the intent of testing is. We're doing a lot of surveillance here because we have the capacity to do so.
And I think in Alberta, I think we're pretty similar to what was just said. We're testing quite essentially anyone who comes in that we feel is reasonable to test, we will test. So there's not really much restriction on that, but it is a provincial thing.
Thank you.
And I'll say the testing is also varying over time, right? So early on, it was highly restrictive, and it is becoming a little bit more liberal as the testing capacity increases. So this is going to vary as well over time.
Question about vertical transmission. Are neonates that are possibly infected, are they transmitters in the hospital setting?
So once again, I'm going to defer to there is a group with specifically looking at neonates with the Canadian Paediatric Society. And so the vertical transmission question is one that is still debated. The current thought process was that there wasn't vertical transmission. There are a number of now case reports that are suggesting vertical transmission is possible, but I still think it's few and far between. So the more likely way that most neonates are getting transmission is mom's COVID-19 positive and transmitting it post-birth. The vertical transmission, in theory, there's a number of interesting case reports that suggest that it's possible. But I will have to defer to the expertise of the neonatologists on that, because that literature is constantly changing.
You noted that there are certain signs and symptoms that would trigger a return to hospital when you're counseling families at post-discharge. What would some of the red flags be?
Does anyone want to tackle that?
I would, hello, it's Evelyn from St. Justin. I would definitely say any difficulty breathing, difficulty feeding, sign of dehydration as the part of the symptom. I think usual recommendation, but taking care of any difficulty breathing.
Thank you. Has there been any association with COVID-19 presenting as a petechial rash? This poster has 2 children with no other symptoms other than the petechial rash and normal labs for CBC.
Anyone heard of that? I haven't. But I don't know.
No, I haven't, Carolyn.
I don't.
Yeah,
Go ahead.
I haven't.
Sorry. I haven't seen it reported anywhere.
Okay.
And I've gone through the China literature pretty extensively, and I haven't seen it there for sure. Vasculitic all the time, but petechial, no.
Another question, is it safe to perform chest compressions with a positive COVID-19 on a patient with a positive COVID-19 with 100% non-rebreather mask while waiting for the team?
Another point of great debate with much regional variation. So I'll let other people on the panel comment as well. I would say it's the P in CPR that definitely requires airborne precautions. And in reality, any patient who is getting chest compressions is more than likely going to require either bag mask ventilation and or intubation. And so certainly if there's time to go in the room, or anybody who's going in the room aware that some sort of respiratory support is going to be provided, then absolutely airborne precautions are necessary. However, there are some centers across the country, though not others, that are saying that simple basic chest compressions from like BLS chest compressions by a first responder may not require airborne precautions. And so going into the room to initiate chest compressions only and then departing the room before there's any sort of airway manipulation may or may not be safe with droplet precautions only, based on what some regional centers are saying. I think in general, we have to remember that in a pandemic situation with a highly infectious disease, we have to remember that there are no emergencies. And we do need to remember that we need to don our PPE adequately before we go into the room to save the life of a patient. And so I would say, though, you need to follow your local regional health authority guidance on that. That certainly there is a risk, particularly once airway manipulation, including bag mask ventilation, is initiated.
It's Karen Grip. I completely agree with Christina. And from an emergency perspective, and being in discussions with other medical directors of the adult emergency departments, this question is likely more of a moot point with pediatrics, because we're always doing some type of airway intervention, because again, the primary cause of arrest in children is a respiratory arrest. In the adult population, that's a little different, as we all know, in that the compressions, it's more CAB than ABC, where compressions are often started before an airway intervention, because the cause of the arrest is much different. So it becomes less of a point for us. The other thing to note is that, similar to doing an RSI and always paralyzing a patient before intubation, one would assume that, with a surgical mask or a numb rebreather mask over the face and doing chest compressions on a patient that doesn't have the capacity to cough or gag, presumptively if they're pulseless, would be relatively low risk. But as has been mentioned, it's debatable across the country at this point.
Thank you. And the final question, because we're out of time, is what is your advice to parents who live in provinces where schools are reopening now?
Does anyone want to tackle that one?
This is a difficult one, I think. At the moment, we're waiting for the final recommendation in Quebec for sending children in primary school safely. We know that they will have some maximal number in each room with some social distancing that will be asked to the children, and we know that it is not recommended for children with any immunosuppressive state or other important pathology to go back to school at the moment. Personally, my little one will go back to school following the recommendation of my provincial health department.
It's Carolyn back here. I think the bottom line is none of us know what the inferred immune status means, and transmission between kids or kids to adults. But I also think that there's a balance to be considered with respect to parents' ability to rejoin the workforce and children's mental health. So I think it's obviously not an easy answer, which is probably why we're seeing variation across the country and how it's going to be done. But there are many factors to be considered.
Thank you.
And I think until you implement it and then track and see what the impacts are, you really don't know. And so I think certainly when Quebec goes back, I think the rest of the country will be looking and seeing what that impact is, and do we need to readjust what we do. And so you're going to see a lot of provincial variation on this, and hopefully we can learn relatively quickly what the right pathway forward is.
Thank you. So that brings our webinar to conclusion. I want to thank Kevin, Evelyn, Karen, Christina, Laurel, and Sid for their time and expertise today. Typically, Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. However, during the COVID pandemic, we're offering special editions of some of our knowledge sharing opportunities. These may fall outside our typical webinar slots. To stay up to date on all of our activities, please sign up, if you haven't already done so, for our Children's Healthcare Canada Spark newsletter. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't watch live, these sessions are all recorded and the recordings made available after the fact on our Knowledge Exchange network. Tomorrow, we're excited to bring you challenges and solutions for delivering home care and respite services during COVID, and that'll be tomorrow at 12 Eastern. And next week, we're pleased to bring you a webinar not related to COVID, a nice change. On May 6th at 11 a.m. Eastern, we're bringing you Beyond Building Blocks, Investing in the Lifelong Mental Health of Ontario's 3 to 6-year-olds with Dr. Purnima Sundar and Dr. Chaya Kulkarni. Thank you. Thanks again for joining us today, and thanks to Children's Healthcare Canada's partners and members, and for supporting our webinar program. And hopefully we'll see many of you back here tomorrow. Bye, everyone.